Good morning, everyone, and welcome to the first CMN Virtual Collaboration Forum of 2021. So thank you for taking some time bright and early on a Thursday morning to join us. We appreciate it. My name is Carrie McNabb, and I'm one of the coordinators for the CMN. I'm very excited to see some familiar faces this morning. I'm going to take us through our introductions before I pass it over to our wonderful speakers this morning. I'd like to kick things off with a land acknowledgement. It's important that we recognize we are webcasting from and to many different parts of Alberta today. So the province of Alberta is located on Treaty 6, Treaty 7, and Treaty 8 territory, and is traditional meeting ground and home for many Indigenous peoples. That we've coined today's session the perfect appointment. So a little bit of a tongue-in-cheek title there, but we're very exciting to present Tracy Fossum, whose talk is on Stop, Look, and Listen, what patients and providers need to know about appointments. And then we're going to turn it over to Dr. Jennifer Burke. Her presentation is called Handle with Care, Difficult Conversations with Patients. Diving into disclosures, I've combined them a little bit here. Your moderators today are Dr. Kathy Scrimshaw, Carrie McNabb, who's myself, and Agatha Grukowski. Our disclosures are that we are paid employees of the Alberta College of Family Physicians. Kathy, would you like to introduce yourself briefly?
Hi, I'm Kathy Scrimshaw. I don't have my video on because my internet is unstable, but I'm a family doctor. Recently retiring from clinical work, and I work for the Alberta College as the medical lead for the CMN.
Thank you, Kathy, and good morning. A couple of other notes. So this program does receive financial support. We received a Health Canada Substance Use and Addiction Program contribution that funds the CMN over the next 3 years. We also receive in-kind support from the Alberta College of Family Physicians. Just to note, this series, the Collaboration Forum series, is certified for 1 credit per hour. There is an attendance link that you will see in the chat log. It's a SurveyMonkey link. So you must click on that link and enter your first name, last name, and email address. And that's what we use to verify your attendance and issue your certificates of attendance. Just a note that for September, October, and November, we're currently collating your certificates of attendance, and we'll send them out to you by the end of this month. A request for you. So for those of you who know of Peer, of the Peer fame, they are currently working on their lower back pain and neuropathic pain guidelines and KT tools, and they're currently looking for peer reviewers. So if we have anybody out there who might be interested in participating in this work, Peer is looking for you. No obligation there, but if you have interest, please click on this SurveyMonkey link. Again, we'll send this slide deck out to you. And we've also posted this request on the CMN discussion board community of practice. So you can click on that SurveyMonkey link and enter some questions that they have for you, and then they'll follow up with you if you're a good fit to be a peer reviewer. Another side note about evaluations, they're extremely important to us. It really helps us pick topics, decide the format, investigate future speakers who you'd like to see present at these events. So there is a session evaluation for every collaboration forum you attend. You get entered to win a $25 gift card prize draw whenever you fill one out. In addition to that, we have a semi-annual evaluation. So you guys have probably seen our emails in your inbox. We've contracted 3 Hive Consulting to do a really comprehensive evaluation of the CMN. Again, this really helps us with our strategic overview of the program in deciding what things we should offer. So not just topics, not just sessions, but things you would like to see change the CMN as a whole. So what supports we offer to members, what elements we should investigate. It's also really crucial for us to support our funding, that we get these evaluations, spend some time on them, and are able to show what the CMN is doing for members of our community in Alberta. So just a note, this is the link to the semi-annual evaluation, and that's going to be open until January 31st. We've also added a little prize incentive here. You'll be entered to win one of 2 100 Visa gift cards as prizes. So again, Agatha will be posting all of these various links in the chat box. If you get confused, she'll post them a couple of times throughout this morning's session, so you have a chance to look at those. And then just going into our agenda, I know it's tightly packed with content, so we're going to start with Tracy Fossum, and then we're going to go straight into Jennifer Burke, and then we're going to have a combined question and answer at the end, as we think that would be great to hear a little bit from both of them. So I am very excited to turn the session over to our first speaker this morning. Welcome, good morning. Thank you for joining us, Tracy. I will hand it over to you.
Thank you, Carrie. So my name is Tracy Fossum. I'm the president of Help Alberta's Pain. And to start off with, there's no conflict of interest. Help Alberta's Pain offers education support, advocacy, and mediation for chronic pain patients and doctors in the province of Alberta. And we do not receive any outside funding. So no, we are not paid. We are all chronic pain patients. The perfect appointment, or what we call it, is the appointment plan, was developed by Help Alberta team in order to help facilitate mediations and improve the experience that chronic pain patients and their doctors have at appointments. Okay, next. Development of an appointment plan. The goal for developing an appointment plan is to improve communications within the appointment and care in general, build a better partnership between the physician and the patient, reduce stress, because let's face it, some of those appointments can be stressful, build a better treatment plan, and then teach your patient how to effectively use their doctor. That might seem silly to some people, but one of the things that we've learned in doing the work that we do is that quite often patients don't understand the best way to use their doctor, which often results in a lot of confusion and problems that we end up having to solve when we come in to mediate. Next slide. Well, we all need an appointment, both of us, the doctor and the patient. We need to be heard. Patients come out of appointments feeling like their condition was not described well, or that they weren't heard in explaining things. Doctors come out feeling like the patient wasn't listening or didn't hear what they had to say. We need time to think. Frankly, many of us have brain fog. As patients, it can be difficult to cram communication and thought into an appointment. And frankly, I can't imagine what it would be like trying to deal with 5 complex things in 15 minutes as a doctor. We believe firmly that the development and understanding of a plan for treatment is critical. We find that patients that have that kind of plan or planning do better, they feel more secure, and honestly, it builds the doctor-patient relationship so that when difficult times come, the patient feels confident and the doctor knows how to communicate with them. And lastly, we need the opportunity to ask questions. You need us to explain more, and we certainly need to be able to ask questions about the treatment plan so that we can do our part and follow the directions as necessary. Next slide. Can a perfect appointment be done in 15 minutes? Yeah, no. Chronic pain, like some other diseases, is an incredibly complex issue, and it comes usually with many parts that need to be addressed. And trying to fit them all into 15 minutes is just confusing, challenging, difficult, and stressful. The lack of time often results in miscommunication, frustration, and we fail to develop a plan or a partnership between the doctor and the patient. We're just talking at each other. And lastly, those appointments that aren't planned well can be really stressful and chaotic. And frankly, from the patient perspective, stress is never good. Next slide. So when we're called in to help a patient and a doctor who are struggling, we usually start with the basics, and we start by breaking down the concerns. So we ask the patient to list 5 concerns that they have, maybe sleep, lower back pain, anxiety, whatever other issues, it's early, that they may have. And then I'd like the doctor to break them into manageable groups. Some doctors do better with sleep, some do better with pain, some do better with anxiety. So they may not require as much time to address those issues. Break them down into manageable groups that work within the appointment time. And then together, the doctor and patient set priorities. So sleep is a major priority for me in this time period of my life. I'm not sleeping, it's affecting my pain, it's affecting my ability to function. So let's make that the first priority on our list. In that moment, setting that priority list begins a conversation in which we're building a partnership. And we're doing it at a time when there isn't a lot of extra anxiety and stress, because we're not having a difficult conversation. We're not having a conversation full of emotion. And it's much easier to communicate and build a partnership at that point. Then we develop an appointment plan to address each individual group of concerns. What we usually suggest is that you break it down into weeks. Week 1, we're going to deal with, say, sleep and spasms. Week 2, lower back pain and headaches. Week 3, mental health and supportive therapies. We space those out fairly closely. One of the things that we've learned is that patients often don't know that that's possible. So what they try to do is cram it all into that first 15-minute appointment. But if they know we're going to get to each one of these concerns, one appointment a week for 3 weeks, one appointment a week for 4 weeks, then they're going to have more confidence about waiting a little bit to discuss it. We also noticed that there are many times that we go in and a doctor is concerned that the patient just keeps showing up for appointments. The patient is making multiple appointments because they don't feel heard, but in each appointment, they just keep going over the same things. So planning these out gives you an opportunity to know what we're going to address and make sure that we keep all of these appointments on track. We're not wasting time, and we're going to get through all of them. And then last, by breaking it down into those kind of groups, we know what the next appointment is going to be. I know that next week we're going to talk about headaches. We can give the patient a handout, or we can discuss in advance the issues that you need to understand regarding whatever the concern is. But also, the patient gets an opportunity to outline or document the things that they're concerned about. Having the extra time to go back and add something else in because you're filling it out over a week is incredibly valuable for most patients. It's so often that we hear a patient saying, I just finished the appointment and oh, I forgot that thing. And sometimes it can be pretty important, but it's hard to remember it all in the appointment while you're trying to talk, while you're trying to listen. So by documenting what you want to cover in that appointment, you get it clear and you get it done in that appointment. The other thing that having that kind of documentation can do is keep the appointment on track. If we have it outlined how we're going to handle it, we're going to start with point 1, point 2, point 3. We can keep going through the sheet until we get to the bottom. There won't be as much bouncing around. There won't be as much waste time. And we schedule in the opportunity for the patient to have time to ask questions, time for the doctor to communicate what the plan is, and make sure that we're both on the same page. Tough talks and well-being. Next slide. So now that we've scheduled those first appointments, and by the way, we schedule those for new doctors and patient relationships. We just transfer the patient over. We schedule those appointments if something's gone wrong, or sometimes once a year to reevaluate the entire situation. But now that we've got those done, we include in the schedule, in the plan, time to reassess the treatment plan. What patients want doctors to know is that if you sneak difficult conversations up on us, we're going to feel threatened. But if we know that those difficult conversations are a part of our treatment plan, and we know that every 6 months we're going to say, reassess our opioid medications, or we're going to reassess our mental health. It's less threatening. We know it's just part of the plan. And by scheduling it in, a patient can be prepared for it and understand that this is just a normal part of pain management. So get those in. And don't forget the discussions like diet and exercise or alternative therapies, because often we need to change those or see if they're working and get extra outside support. So schedule them in, plan once every 6 months to do that. We also encourage a plan for yearly physicals. It might seem really basic, but most of the chronic pain patients that we work with have not had a yearly physical in an incredibly long time. And the reason is we see our doctor every month, every 2 months, every 3 months, and patients seem to think that means if something's going wrong, their doctor will catch it. But we all know a physical is more than just taking blood pressure. So if we make it clear that a yearly physical is a part of this plan, and we tell the patient every December we're going to have a yearly physical, and they book it in, they plan for it, we can keep an eye on potential problems down the road and help ensure the health and well-being of the patient for a long time. It's also important in this appointment plan to talk about follow-up appointments, refills, and intervals. I cannot begin to tell you how many times we hear a doctor say, well, they only come in when they want refills. Well, if you want them to come in every month so that you can follow up and make changes, then we probably need to communicate that to the patient. So have that discussion, schedule it in, write it on a calendar so the patient knows how often you want to see them or what kind of circumstances you would want to see them in. And lastly, don't forget to schedule in discussions about other critical health issues. For example, blood pressure, diabetes, anemia, things like that. When we're talking about pain, it's such a big part of our lives that it's easy to forget about your blood pressure. In the moment, that blood pressure isn't causing me any grief. So if I have 15 minutes with my doctor, I'm probably not going to bring that up, but I will bring up the 5 days of headache that I've had. If we don't make a plan to schedule in those conversations, they can be forgotten. So now at this point, our plan looks like the first 3 weeks are planned, breaking down our objectives and what we need to talk about. And then we've planned for how many times we're going to come in or how often we're going to come in for follow-ups. We planned our yearly physical. We've made it clear that once every 6 months, we're going to have a discussion or assessment about our treatment plan. And we've made an agreement that once every 6 months, once every 3 months, we're going to discuss our diabetes or anemia or whatever it is. At that point, a patient has already begun to change their attitude towards the doctor. They start feeling a greater connection, knowing that your doctor is thinking about all of these things and seeing some display of that, evidence of it, gives them this feeling that there is a connection. And then next slide, last but not least, crisis planning. This goes wrong so often. How would you like your patient to handle a new or growing issue? Oh my goodness, we get calls from patients who sat around for 2 weeks watching the flare get worse and worse and worse. And then finally on day 14, Friday night at 9 p.m., they wind up in an emergency room. The next week, they have their follow-up appointment with the doctor, and his response is, why didn't you call me? Usually the answer is, I didn't want to bother him. I know my doctor's busy. I don't want to appear to be one of those patients. Except that often, if a doctor could intervene earlier, we could change it or improve the treatment plan. So how would you like them to handle those kind of crisis appointments? If it continues to get worse for 3 days, come in. If it reaches this level, go to the hospital. If it's urgent, we have an after hours number. Most patients don't know how to contact their doctor or leave messages after hour, or if there's an after hour number. And last, when we make those urgent appointments, How should we make them and to who should we make them? Sometimes there's a nurse that we can call, and that would be the best way to do it. How about an email address to send the question, this is going wrong, should I come in? Is there a time that the doctor is in the clinic taking walk-ins or after hours? When a patient knows that there is a plan for handling a crisis, they're more likely to use it and less likely to wind up in an emergency room because they can't handle it. In general, the goal of this plan is to help build that communication around a plan for appointments, but it does so much more. It builds a partnership, it facilitates communication, and it helps a patient feel connected to their doctor, takes confusion out of the appointments, and overall gives you time and preparation for the difficult talks that you need to have when it comes to complex issues. Thank you.
Thank you, Tracy. That was amazing. You've condensed a lot of amazing information into a short amount of time. We truly appreciate it. We're going to go right into our next session with Dr. Burke, but we will have a joint discussion, question and answer with Tracy and Dr. Burke right as soon as Jen is done. So thank you, Tracy. We're going to turn it over to Dr. Burke, and I'm just going to let her share her slides.
All right, so I'm going to talk a bit today just about what we view as difficult conversations with patients. My disclosures are that I'm not an expert in chronic pain or addiction, but I am passionate about communication in healthcare, which I suspect is the reason I was asked to do this, and that I was previously in some senior leadership roles at AMA and at AHS, but I'm no longer in those roles. So the learning objectives for today are to articulate what factors can make a conversation difficult, to be able to prepare for and initiate a difficult conversation, and to apply strategies to support effective and compassionate communication. And again, this is a topic that is very broad. So you're just going to get like a sniff of one particular area, but hopefully there will be something useful that you'll take away from this. So we're going to start with, it's just another manic Monday, and you're heading into the office for the week, and you get there and you see your list for the day, and this is how you feel. You're not a bad person. You're just a human being. You're experiencing some negative feelings, anticipating a difficult encounter, maybe because there was a previous difficult encounter. There's likely a triad of emotions running high, both in yourself, potentially there was in the patient. Maybe there's high stakes. It was an important conversation. There's something you're trying to achieve. Perhaps it's becoming in line with guidelines or with your colleagues, making sure that you're following the college's recommendations. And then the third piece is that there may be differing opinions between you and the patient or a strained therapeutic relationship. As a professional, it's part of our job to learn how to navigate these conversations as well as we can so that our patients can have successful outcomes. And of note, I really do not believe that we get enough training in difficult conversations throughout our formal medical education. So there are some specific types of conversations that I would lump under difficult, though in truth, any conversation about any topic in medicine that evokes negative feelings in either the provider or the patient can risk becoming difficult if there are poor communication skills. So the sort of classic ones would be breaking bad news or goals of care. Many of the same principles we're going to talk about today apply, but that's not the focus of the conversation. Disclosure of adverse events is another type of difficult conversation. Again, not going to be covered really today, but there's some great courses out there. And I will mention one, if you do happen to have an AHS medical staff appointment, there is a free course called Communicating Unexpected Outcomes in Healthcare. And I only mention it because I was facilitating that course. It's a great course. But mostly what I'd like to talk about is responding to what we view as challenging behaviors or encounters. And I think sometimes substance use, addictions, and chronic pain can fall under that category. There are many factors that can contribute to making the conversation difficult. I'm going to just sort of zoom through these, but I think you'll see they're fairly common sense. So patient factors, their preferences, their values, if there's an unrecognized personality or psychiatric disorder, those who may be attempting to manipulate, and maybe they're not even intentionally trying to manipulate, those who are grieving, frequent flyers, somatizing patients, patients who are just angry, defensive, frightened for other reasons in their life. Physician factors also play a huge role in making conversations and encounters difficult. Maybe they're not prepared, maybe they haven't been trained. A big one is maybe they have discomfort with their emotions or a lack of self-awareness. They actually don't recognize as physicians what they're feeling. Their own personality traits. Burnout is a big one. If you have no capacity left for essentially for caring and being compassionate. And sometimes fears play a big role here, being blamed, unleashing a reaction in the other person, expressing emotion, fearing that you will express inappropriate emotion. The situation can contribute if there are cultural differences or barriers or expectations, if there are family dynamics you're not aware of and other people present in the room who might triangulate the discussion, if there are language or literacy barriers, a loud, busy environment with inadequate privacy, limited time, constant interruptions. As Tracy highlighted, the time is a key one. But I actually think the biggest thing is if you don't have a pre-existing relationship with the patient, because having a healthy relationship that is based on trust, empathy, and confidence in the physician is actually the first step in preventing encounters from becoming difficult. Also want to say that we often talk in medicine amongst ourselves as patients as being difficult, but that's not appropriate. It's relationships or situations that are difficult. And sometimes there's actually a relationship issue. It's like a marriage. Sometimes there's a relationship issue. 3 classic ones that seem to create difficult emotional visits are frustrated success. And this is when the disease just isn't responding to treatment for any number of reasons. The treatment just isn't working, and the patient and the provider effectively start blaming each other. Inflexibility, and this is when either the patient or the provider just dig their heels in and they are not going to budge on a negotiation for a treatment plan, and the relationship and the conversation can become very difficult. And then the one that I think is probably the most common is misaligned expectations. And I heard a great quote on CBC years ago: the #1 destroyer of relationships is unmet expectations. You can take that and apply it to any relationship in your life, and I would say that that is true. There's only so many things from all those different factors and relationship issues that you can control as the provider. So you need to do your best to be prepared. So you are prepping for your first encounter of the day, the one you anticipate that will be difficult. So you need to prepare with intention. Just popping in the room and trying to make it work is probably not going to be successful. So #1, you need to familiarize yourself with the patient in the case. You may have a long-standing relationship with the patient. If you have any new information, absorb it into what you know about them. Do pre-charting, review medical history and social circumstances. I can't emphasize that last part enough, because we know how much the social biopsychosocial model, the social circumstances can impact people's well-being. Review any questionnaires you've done ahead of time. You do not want to hear the patient say, well, you should know that, it's in my file. #2, consider what stories you are telling yourself. This is actually right out of a course that I absolutely love and I have absolutely no stake in any way, but a course called Crucial Conversations that you can take through Jewel at CMA. It is important to recognize that sometimes you tell yourself a story about somebody and it may not be true. So you need to think about, what have I heard? What have I seen for myself? And what conclusion have I come to on my own? Because the story you tell yourself can change your whole attitude towards a person and an appointment. Very quick anecdote. When I was a resident, I once was called to see a lady in the emergency department in a rural hospital. The nurse told me she's a frequent flyer. She's been coming for 20 years. She has chronic headaches and she's here for her Demerol. Can I just give her the Demerol? And I said, I don't know, maybe I was a resident. I was keen to sort of explore everything. And I said, no, I'm going to come and see her. I went to see her. And long story short, the result was This patient was sent for a CT head and was found to have a 7-centimeter AVM taking up an entire lobe where her brain ought to be. That was not something that developed. That's something that had been there her entire life. And my fear at reflecting on that was that people listened to the stories other people told about that patient instead of sitting back and actually getting their own information and essentially giving the patient the benefit of the doubt. Third, pause and focus before you go in the room. A mindful moment is going to go a long way to help you with number 4. The mindful-based stress reduction strategies you can use could be as simple as 3 slow, deep breaths before you go in the door. Maybe in these times, it will be while you're donning your PPE. Think about what your focus and your intention is for this visit. And you really need to leave your biases at the door and focus on respect. And number 4 is having a plan for managing your emotions. Sometimes the provider emotions are indeed what derail a visit and make it difficult. So when you're uncomfortable as the professional, you need to be able to model calm, even behavior instead of getting upset. If you get defensive or angry, that is not going to help. You need to know your triggers and your boundaries, and probably plan some reasons if you expect it to be difficult. If you think you might need to be able to step out of the room for a moment just to get your wits about you, have a plan of how you're going to do that. Good self-care and avoiding burnout is one of the best ways to manage your emotions. So as you're about to walk in the room, you think about the fact that compassionate communication really requires 3 things: that you do have good nonverbal and verbal communication skills, that you be an exemplary listener, and that you demonstrate empathy. You need to avoid being task-oriented and be people-focused. So to initiate a difficult conversation, again, at this point, I'm kind of assuming that you don't have a long-term relationship with this patient, but how do you sort of start? And this is where you really need to ask the patient to tell you their story, or you need to hear from them what it is they want to talk about today. And you need to actually listen intently and completely. I have a tool that I use. I've used it for years, and I can give you background on the tool if you like when we do questions. But it's a little card, and it says, wait. And the wait stands for, why am I talking? And I often plunk that down in front of me, either in patient encounters, I have it on my lanyard, or even in a meeting, I put it down in front of me at times. Do not interrupt the patient. Make sure you've given them appropriate time. Body language and the setting matters. If you are not making eye contact with them and you're looking at the screen, or you're typing, or you're charting, they are not going to feel like they are being listened to. If they get through their story and they haven't talked to you about substance use and you need to ask more questions, then ask their permission. Ask if they would be comfortable telling you more about their substance use. And now that you've listened intently, I bet you that they will be more trusting to give you more information. The second key thing about initiating the conversation is, again, you have to go in conveying respect and a non-judgmental attitude. Everyone is someone to somebody, and it's important to remember that people are people. A great anecdote that I find helpful is to remember what the hostage negotiator needs to do. They need to convey respect to the hostage taker. Now, I realize this is an extreme example, but when I tell you what they do, it makes sense. They have to convey respect to this person who has done awful things, or at least the stories they know about them is that they've done awful things. The hostage negotiator goes into this is a story I heard, goes into the bathroom prior to getting on the phone with the hostage taker, closes their eyes, takes a mindful minute, and imagines that hostage taker as a 5-year-old getting their first bicycle, as a 12-year-old going to their first Little League game, as a 16-year-old going on their first date or having their first kiss. Then, without talking to anybody else, they go to the phone and they talk to that person because they have just found respect for this person as a human being and not based on the circumstances that they are currently dealing with. And that is what you need to go into the room with. While you're in the room, you need to try to understand the patient's goals and their outcomes, what matters to them. Agree on what matters most. Try to make that list of shared priorities like Tracy talked about, and don't try to boil the ocean in the first visit. Consider also how their social circumstances might be influencing their health, and use that to help you determine the treatment options. Connect with their story. Focus on the positive things they've been able to achieve so far. Celebrate their successes. Make sure to be careful about language. If you're in the conversation and tension develops, this happens. Tension indicates a relationship problem. So, as the provider, you need to pause, recognize what you're feeling is that there's tension, you're having negative emotions. Assess the source. What factor is at play here? So think about those factors. You have to identify the relationship problem. So going back to those, is it an issue of misaligned expectations? Is it inflexibility? What is it that is causing the problem here? You have to commit to yourself that it is important to you, that you are going to work on the relationship in addition to whatever the medical problem is. Then you will acknowledge that difficulty verbally to your patient and offer a problem-solving approach. And you may need to clarify the reason why they're seeking care in the first place. But ultimately it says, I want to make sure, it seems like we have some tension in our relationship. I want to figure out what it is that's driving that. This is the goal we're trying to achieve. Here are some ideas I think on how we can get there. What do you think? So to improve partnership, you actually do need to point out sometimes that the relationship is less than ideal and offer ways to improve care. That can be difficult. And if you must express a negative emotion as the provider, if the source of the tension is something that you need to address how you're feeling, always use I statements, never blaming statements. I feel this way right in this moment. This is why I'm having difficulty. And that will help open up a conversation potentially. You verbalize your expectations. You need to set them. You need to indicate what role the patient must play in caring for their own health and what role you're willing to play, and revise if the expectations you've previously held are unrealistic. You need to negotiate the plan of care and be careful, though, not to get trapped in an unhelpful discussion. I found this great resource through the Oregon Pain Guidance. They have a great website, a whole page on difficult conversations. And one of the pages is about common traps and negotiation strategies, and positive ways to respond to those. So for example, an all or nothing trap, if the patient says, so you're not going to do anything for me then, how you respond to that in a positive way to move the conversation back to trying to come to a shared goal or a shared decision. There are other traps like compassion traps, addiction labeling traps, desperate or threatening traps. Be very careful to remember your own safety, and then end game, that this is a be all end all kind of conversation. The goal is ideally shared decision making. That's where you want to get to, and you want it to be patient centered. You want it to align with their desired goals and offer up to, one of the resources I saw set up to 3 options for treatment. It's important to stay in the medical expert role and trust the science behind your recommendations. So boundaries. This is a question that comes up for people sometimes. How do I respond to inappropriate patient requests? How do I get to know? So I found this great little mnemonic that I'll just quickly go through for you. So F, so it's favor. Recognize your uncomfortable feelings. Listen to your spidey sense. If the request you're getting was appropriate, you likely wouldn't be having uncomfortable feelings about it. So then quickly analyze, why do you feel uncomfortable? Usually this can be mapped to one of the 2 following. Either fulfilling the request would be poor medical care for this particular patient and their case, or fulfilling the request would actually be illegal, dishonest, or against policy. V, view. Patients may assume that the patient knows the request is wrong, and this can be influenced by many factors we discussed previously, like burnout, fatigue, time pressures, the stories you tell yourself. The goal is to actively assume that the patient does not know that what they're requesting is inappropriate. And remember that certain behaviors can actually be expected with certain illnesses. Just like for diabetes, how we expect people to have high blood sugars, we might actually expect those that have substance dependence to manipulate to get more of what they need. And that doesn't mean they're trying to be a bad person. So this approach can help you maintain the relationship. So make sure you think of them in the best possible light. Explicitly state why the request is inappropriate. Say it's because of poor care, it would be dishonest. Avoid lengthy explanations that move you away from your original statement, because you don't, in situations like this, you don't actually want to create room for debate. You don't want to talk about your comfort level. I don't feel comfortable doing X. Not helpful, can make patients upset because you're thinking about yourself and not about them. Don't make a statement, then shift your position. This can erode trust. And don't give in just a little. That can set precedent for yourself. And honestly, it probably will just kick the can down the road. Don't hesitate at this point before you make your statement about why it's inappropriate. If you have to use your moment to go get a breath outside and gather your thoughts, do that, because you're trying to salvage the relationship. And then last is rapport. This is where you have to use empathetic statements. You have to accept the patient's negative emotions. You have to validate them with your empathetic response, and you can't get angry or defensive about their request. You can use I wish statements. I wish I could do X, but it would be dishonest. It needs to be genuine, obviously, but that can be one way to try to salvage the relationship. This tool, there is a paper, the references in the references, and I can give you more information if you require it. When we're talking about the emotional cues and the empathy, it's really important because empathy and patient-centered care has a huge impact on health outcomes, particularly in chronic pain. So when a healthcare provider takes an interest in a patient's pain experience and then actively involves the patient in their care, it fosters trust and allows them to participate more fully in the treatment. It's particularly important and can be challenging because as physicians, we often learn to emotionally detach. Partly we tell ourselves in order to be objective, but actually this can lead over time to empathy degradation. So it's really important to, if you feel like you are not skilled at expressing empathy, you don't want to be what we'll call an over empathizer, but you need to empathize appropriately like a human being. And there are some techniques that you can teach yourself and learn and practice to get better at this. And one of the mnemonics is called NURSE. And this is essentially naming the emotion that you think the patient is experiencing in that moment. So saying something like, I'm wondering if you're feeling angry about what just happened. So actually putting a name to it and validating it. Or understanding, considering what you're going through, I could understand why this would be stressful. Respecting the patient. You know, I admire how much you've been through on your journey, or I can see that you've worked really hard to achieve X. Supporting them. No matter what happens, my team is here to support you. I'm here to support you. And then exploring. Tell me more about how you're feeling right now. What's on your mind? Showing an interest that how they feel actually matters to you. It can be difficult to express empathy when our faces can't be seen. This is myself and a good friend wearing our everyday PPE recently. So you cannot see very much of a person's face. At the beginning, you'll remember I showed you those emotional pictures. Well, you knew what people were feeling because of the expression on their face. So this makes things very difficult when you don't have facial cues, because this can impede your ability to express and recognize emotional cues and build trust. There was actually a study back in 2013 that demonstrated very clearly that doctors wearing a face mask had a significant negative impact on the patient's perceived empathy, and it diminished any positive effects of relational continuity. So it can have a huge, huge impact. So what do we do about it? Well, while you're in PPE, remember that body language matters more than ever. Body position, orientation, eye contact, use of hand gestures. The tone and volume of your voice, as well as how well you articulate and enunciate, matters more than ever. If the patient has patient sensory deficits, or if the patient has sensory deficits like hearing loss, do they need a pocket talker? Your voice might be muffled under the mask. Use plain language, no jargon, and frequently pause to check for understanding. You can empower patients. Again, I love cards. So the one I showed you before, the back actually says jargon alert. So another way you could use this is actually giving the card to the patient and telling them, if I start using jargon that you don't understand, hold this card up and I will not be offended by this, and I will realize that I'm speaking in a language you don't understand. The other card, and this is all done at through the Health Sciences Education and Research Council up at the U of A. They're actually doing studies at the Glen Rose Rehab Center using these cards. But the other card is one that says, I have a question. And you can give this card to the patient. And on the back, there are a few comments that say, you can say, please slow down. Can you help me understand? Please repeat what you said. Can you say it in a different way? Giving them this allows them to interrupt you without verbally interrupting you. And it's a more, I think, respectful way of saying, I want you to be part of this discussion. I don't want to give you 10 sentences of information and then have you get lost after the second sentence. You can make a face sheet for your office so they know what the faces look like and that they at least can imagine what your face is looking like under your mask. And ultimately, you need to shift nonverbal to verbal by using more nurse statements. So a few take-home points. Self-awareness and emotional self-management is key to successfully navigating a difficult conversation. You need to take an interest in the patient and their story. And I suspect you wouldn't be here today if that wasn't something you desired. This will go a long way to building relationship and trust. And remember that patients are human above all, and respect is deserved for that fact alone. There are no difficult patients, just difficult behaviors and relationships. If you want more training, practice with your learners. They're going to be a resource for you and a place for you to practice and for them to practice. Direct observation. But the biggest thing I think for us as professionals is I find that these communication skills are translatable between many different realms of our profession. Take courses, read books. I put some key ones on here. Crucial Conversations, hugely worth it, is actually a book. You don't necessarily have to take the course. And then that Oregon Pain Guidance website, it was one that I happened across when I was preparing for this, has some excellent resources there. Just in order to empathize with someone's experience, you actually must be willing to believe them as they see it and not how you imagine their experience to be. So I think that's a really important thought to leave on. Thanks.
Yeah, thank you so much. Sorry, I have a couple of questions actually to throw out to both of you. Yeah, so for Tracy, what are the most common issues you're seeing in your work with mediation with doctors? What is the biggest issue that sort of triggers that type of mediation? What are the difficult conversations that patients have to have with their doctors, and how do you prepare and sort of train your mediators as they go into a doctor's office?
Well, I think that the first and most difficult one is a patient explaining their pain experience and feeling like they've been heard or understood. And the fact is, we carry a lot of baggage. Most of us who have been doing this for a long time have had many, many, many bad experiences. And it's hard to sometimes let that go with a new doctor or in this relationship. And so when we go in, we're sort of prepared to not be heard or feeling like we have to fight to be heard. And a doctor with the greatest of intentions can inadvertently leave a patient feeling like they're not being heard. And it can be also nobody's fault in general, just trying to do it in 15 minutes. For example, a patient can only remember about 35% of what's said in an appointment. Recently, we had a patient complaining that her doctor never takes her sleep seriously, ever. And when we went in to mediate, what we discovered is that the doctor was adjusting a medication that the patient didn't understand was being used to help her sleep. And so he was doing that each time. But because it wasn't a sleeping pill that she knew, She didn't understand that's what he was doing. It wasn't communicated. She felt she wasn't heard. He wasn't taking it seriously. He felt she was being difficult and drug seeking. And in reality, it was just we needed to talk about sleep. So we find that those conversations in general can be difficult. When it comes to things like opioids, reductions, reassessments, maybe benzos, sleeping pills, things like that, the reason why most of them are difficult is because a doctor comes in prepared for a fight, a patient comes in prepared for a fight, and it is a stressful, difficult appointment, and nothing usually comes out of it that is any good. But when a patient knows in advance that this is just a part of the treatment plan, and that it's a discussion that needs to be had, it melts away a lot of the tension. And lastly, how do we prepare going into it? First of all, we talk to the patient. We get more time with them than you do. We get I can spend an hour talking to a patient. We explain to them some of the difficulties that doctors have. We explain to them why what they're doing may not be effective, that they're going in looking for a fight. We talk about what the goals are. And then when we walk in, our goal every time in the first 5 minutes is to set up a collaborative partnership between the three of us to begin to facilitate a better communication, start creating the most simple plan, something small that we can have success with. And then from there, it can build. So that's pretty much how we address it.
That's great. Thank you. I don't know if anyone else has questions. I don't want to hog it all because I have another question for both of you. Now, Jen, I know you've been working on the wards in Chinook Regional, and I'm wondering how the pandemic and virtual care has impacted both of your patient populations in potential difficult conversations, not even just about pain, but about other things. And certainly the issue with masks comes into mind, and also how to have an advocate in a virtual conversation and how that works.
I can start by commenting on, what it's been like at the hospital. Certainly one of the most obvious challenges has been if you don't explicitly state who you are, they have tough difficulty recognizing different people when all they see is this. So you have to identify yourself verbally every time you come in the room and describe your role. So that's definitely been a challenge. I think the other really big challenge has been around the non-medical supports for patients. So patients who come in we have patients who have addictions, for example, in hospital frequently with secondary medical issues. They're not there primarily for their addiction issue. And once we remove the ability to allow them to, something as simple as going out for a cigarette. So if we remove their ability to be mobile around the unit, if we remove their ability to have visitors and get emotional support from their usual support people, and tell them it has to just be virtual, this has had tremendous negative impact. In some cases on patients even being willing to stay for medical treatment. So it has made the conversations very challenging.
Tracy.
So from our point of view, our biggest difficulty has been treatment that patients were reliant upon not happening, and patients and doctors having difficulty having communications or discussions around what to do temporarily to cover that gap. So we have patients that are really struggling that probably needed some other medication assistance because they can't get to physiotherapy or their injections or whatever. And those discussions have become more difficult. As far as virtual, we are so loving it. The reports that we get from patients is that their relationship with their doctor improved when they were using Zoom. And part of it, I think, is we hurt, we get in a car, we get ready, we get dressed, we get in the car, we travel, we wait in the waiting room, we finally get in there, we're more sore, we're more tired, we're a little more cranky. But also, we found that doctors staring at the computer to talk to you aren't necessarily staring at the computer typing notes all the time through the appointment. And so there has been an improvement in doctor-patient relationships. When it comes to an appointment where we need to mediate, it's given us the ability to reach more areas quicker. Just adding us in to a Zoom call, or we can three-way conference on a phone call, has been really advantageous. The one thing I do want to just sort of point out, because this has happened a couple of times, we can see you on Zoom meetings. We've had a few doctors that forget that. They forget that that particular computer is looking back at them. So we've had doctors rolling their eyes or expressing their frustration visually and forgetting that the patient was there. So that can be a bit of a problem. But overall, I'm really hoping that this kind of virtual care continues.
Well, that's great. We do have a question from Jess. I don't know if you want to unmute, or I can just read it, but she's asking about recommendations to build and maintain trust and rapport when potential violence is an issue. And Jess works at the Boyle Macaulay in Edmonton. They use a trauma-informed approach and trained in nonviolent crisis intervention, but struggles sometimes when she's physically afraid, patients with a violent history, possible weapons, that kind of thing. Any comments from either of our speakers?
I'd like to take a shot at that. First of all, I like the trauma-informed approach. When first and foremost, get a partner. I mean, when we see violence, it's not as often in Canada, but we see it more in other countries, but it can happen here. If you feel that there is a threat or a potential threat, bring in a partner. It doesn't have to be we're teaming up on you. Just bring somebody in to take blood pressure while you're doing something else. Have a teammate there so that you have two eyes on the problem. Be safe. And secondly, one of the things that we know from dealing with a population that often feels incredibly stressed or threatened by the medical profession is that when we come in hot, when we come in angry, if the first person we meet is already prepared for that fight, then it's likely going to escalate. So right from the beginning, whoever is sitting at the desk, greeting them when they come in, there has to be a plan through the entire team to stay calm, stay positive, smile, nod, and express understanding. If we have one person in that lineup that is willing to act aggressively or willing to act frustrated or to show disdain, then that reaction from the patient will carry over through the rest of the team, and it may escalate as it goes on.
Jen, do you have any comment?
I have to admit, this is probably an area where I don't actually have a ton of experience, and I didn't specifically come across any resources giving any recommendations on this specific thing. I suppose I would just say make sure that you know who your people are, right? And probably these are situations where you don't want to be alone, and that's the obvious thing. Yeah. Sorry, I don't have much more to add there.
No, that's great. Thank you. So I'm conscious of the time. I think we are, yeah, we are over. So Carrie, some last minute housekeeping items.
A huge warm thank you to our speakers, Jen, Tracy. We truly appreciate you taking the time for this. Again, people who are able to attend, thank you for taking time out of your morning. If you liked this session and you have any comments about it, if you could tell us through evaluation, it means the world to us. That's kind of how we measure our beans here at the CMN, is through our evaluations. So just a note, there's a session evaluation that's specifically on what you just heard this morning, but we're also doing a semi-annual evaluation, which goes over much more than just these collaboration forums, but the CMN program as a whole. Please take the time to fill those out if you can. We've got some pretty great prizes to incentivize maybe some responses going forward. But just a note that I know we covered a lot this morning. We've been given permission to record this session and share it with you along with the slide deck. So we'll take those away and look in your inboxes probably next week, where you can review those at a later date and have a look at some of the resources and references that Jennifer mentioned. Otherwise, have a great rest of your morning. Thank you for spending it with us. Huge thank you to Jennifer and Tracy. We truly appreciate it. Have a great day, everyone.